Today we have Dr. Michael Maynard, who's attending orthopedic surgeon at Hospital for Special Surgery, and he's here today to talk to us about the CoLS knee ligament repair system. So to get started, thank you very much, first of all, for agreeing to talk to us.
My pleasure.
How did you first hear about the system, and why did you decide to try it out?
About 2 years ago, I was introduced to the system at the Academy of Orthopedic Surgeons convention, and it just seemed like to me, a unique, new way of using hamstring tendons for reconstructing anterior cruciate ligament injuries. I had used hamstrings in the past, but had been unhappy with the fixation and with the ultimate performance of the graft. And so for the past 15 years, I had been doing almost exclusively bone-tendon-bone autograft, which throughout at least the United States, at least half of the surgeons in the United States use bone-tendon-bone.
And so for which patients would you say the CoLS might be best suited?
Well, we'll back up a little bit. At that point, I said I was looking for something that could that the patients would have a better experience than with the reconstruction than bone-tendon-bone.
Right.
So my feeling was that perhaps everybody would do better. The main problem with the bone-tendon-bone autograft is that we would take a piece of the kneecap that would then hurt quite a bit and cause some inhibition of the quad muscles, and just in general, most patients would have a painful, long recovery from that surgery. So I was looking for an alternative. What happened is when I saw this program, it was something that was being brought to us from France. I decided to go visit some surgeons in France. So I had originally seen the system in, I think, February or March. I went to France in May, and then invited one of the surgeons to come back and operate with me the following September. And that's when I began using it. Over the first 6 months, I continued to do some bone-tendon-bone autografts and some CoLS hamstring autografts. And by the end of 6 months, it became clear to me that the people who were getting the CoLS were doing so much better that the only question in my mind was, how were they doing objectively with how stable were their knees? And at 6 months, I got some objective evidence, using the KT1000 arthrometer, that they were doing at least as well as the people who had what had before been considered a stiffer, stronger graft.
Right.
So at 6 months, I switched over entirely to all comers, and these people, it is such a clear difference in terms of how much less pain they have, how much quicker they have return of their quad function, how soon they can get off crutches and stop using a brace. And I think there's no doubt that this is a superior way to go.
How did you adjust your surgical technique for the CoLS?
Well, the technique, first of all, we still start off arthroscopically. Instead of making a vertical incision where we take a piece of the patellar tendon and bone, I've been making a transverse incision and harvesting one hamstring tendon. That's the main difference in the graft harvest or graft preparation. Then we take the graft, the tendon, the hamstring tendon, to the back table and basically loop it and make it into a composite that has 4 strands that are bonded together. And we put it under tension to take what's called creep out of it. So we take the creep out of it and make it a very stiff, solid graft. The next thing that has changed is the tunnels that we traditionally made for ACL reconstruction were through and through, from the cortex to the right inside the knee. This new technique is only a socket that we make, so it's not a through and through bone tunnel. So it's bone preserving. There's less pain from the tunnel.
Right, right.
And very important to me is that, particularly on the femoral side, there is a complete ability to put the tunnel exactly where you want it. Whereas the traditional endoscopic technique of putting a bone plug up from the inside, there are some restrictions based on trying to do everything from the tibial tunnel or from one of the anterior portals. The CoLS technique eliminates that problem. You can put the tunnel wherever you want.
Now the CoLS has been used primarily in Europe. It's pretty new in the U.S.
Yes.
Generally.
Yes.
Just kind of in closing, are there some studies coming out or some literature that we might look to on this?
Yes, you're right. That most of the experience is in France and other European nations. Several thousands of happy surgeons and patients. In the United States, it's on the order of hundreds at this point, as far as I'm aware. My plan is to become involved in prospective evaluation, comparing objectively as possible the use of this technique versus what I had been using before, and which is bone-tendon-bone autograft, and possibly some other types of using the hamstring to try to prospectively determine, or at least quantify in a scientific way, what is the patient's experience and what is their ultimate outcome in terms of function.
Wonderful. Well, Dr. Maynard, I want to thank you so much. It was great talking to you.
Thank you very much.